spine endoscopy, transforaminal, interliminar, cervical, anterior posterior approaches, vertebroplasties, kyphoplasties, cool RF. He uses all the technologies, including ultrasound, fluoroscope, spinal cord stimulator. He has a lot and lot of
Saurabh?
and he was in Secretary ISSP MP ISSP Indore City Branch IPM since February 2025. He has been examiner in various IAPM exams. So, dear students, you will get a lot of insights from him and madam as well. With this, he has various national and international publications. So, Dr. Anshul, all to you.
Thank you, Dr. Kashinath. So, welcome, Dr. Ruchi Gupta, madam. Dr. Ruchi Gupta, ma'am, is professor and head of anesthesiology and pain medicine in SGRD Institute of Medical Sciences and Research. She is running pain clinic since 25 years, and she is having lot of publication in national and international journals. She was awarded with the Best Teacher Award in 2024. And one thing that I must mention here, that she has conducted very successful ISSP on Amritsar few years back. So over to you, madam.
Thank you, Dr. Anshul. So, today I'll be talking about the medications and drugs in the interventional pain management. This is a topic actually, it's a very vast topic, but there'll be certain things which will be not covered, cannot be covered. In fact, everything cannot be covered in such a short time, but I'll try to do the justice. So I'll be covering the topic as pharmacology of local anesthetics, clinical use of local anesthetics, corticosteroids in pain intervention, adjuvants in pharmacological agents, neurolytic agents, safety, toxicity, complications, and management of these complications. So first is the pharmacology of local anesthetic. So, and local anesthetics are divided into ester group and amide group. Ester group, as all of you know, that it is metabolized by plasma cholinesterase, short acting, high allergic risk, and cross reaction with sulfonamides, and these are procaine, tetracaine, benzocaine, cocaine. And amides are the hepatic metabolized drugs, long acting, low risk of allergies, avoided in severe hepatic failure. These are routinely what we are using is lidocaine, bupivacaine, ropivacaine, levobupivacaine, mepivacaine. So the mechanism of action is it acts on the voltage gated sodium channels, and the local anesthetic diffuses into axons in unionized form. It ionizes intracellularly because of the lower pH and then binds to the inner side of the sodium channel. It blocks the depolarization and no action potential. And these are the mechanisms probably all of us are aware. And since all of us are anesthesiologists, we have dealt with the mechanism of action of local anesthetics. And they have a differential nerve blockade, smallest to largest. And that depends upon the smaller diameter, higher firing, and less myelin, easier to assess. That is how it acts. The C fibers, that's why C fibers, which are unmyelinated activity. Can you hear? No. So next is alpha A delta fibers, which are smaller size as compared to A beta and A alpha fibers, which are motor. So what is important is how it spreads. The onset of spread, depends upon pK values. Lower the pK values, faster onset. Lidocaine has a pK of 7.9, it is faster. Bupivacaine has 8.1, it's slower. And the alkalinization with soda bicarb speeds the onset. Duration depends upon the protein binding, that alpha acid glycoproteins. Bupivacaine is 95% bound, so it has a long duration. And versus lidocaine, which is 65% bound, it's a short duration, 1 to 2 hours. Potency, lipids depends upon the lipid solubility. And bupivacaine is 4 times more potent than lidocaine. Ropivacaine is slightly less potent than bupivacaine. Additives that alter PK, in addition, is epinephrine and hyaluronidase. Epinephrine causes vasoconstriction, decreases absorption, and doubles the duration and reduces systemic peak levels. And hyaluronidase increases the tissue spread. That's how their actions are prolonged. So these are the various local anesthetics which we have been using: the lidocaine, bupivacaine, ropivacaine, levobupivacaine, and these are all amide drugs, and they have usually action 15 to onset 15 to 30 minutes or 25 minutes, except lidocaine, which is 2 to 5 minutes, and so duration is also shorter in 1 to 2 hours, versus all these bupivacaine, ropivacaine, which has 4 to 10 hours approximately. But what is very important for all of us is to know is the maximum safe dose we can use. Is lidocaine is 3 milligram per kg, 7 milligram per kg if it is with epinephrine, and maximum in that situation 400 milligrams can be given. Bupivacaine is 2 milligram per kg, ropivacaine is 3 milligram per kg, and levobupivacaine is 2 milligram per kg. So what are the clinical uses of local anesthetics? It can be used in labor or surgical analgesia. So ropivacaine 1% to 0.5%, bupivacaine also 0.1 to 0.25%, along with fentanyl. So if low doses of epidural are like low doses of use, then we use it for labor analgesia. If higher concentration, then for surgical blocks or postoperative surgical analgesia. Transforaminal epidural steroids, we use smaller volumes, usually 1 to 3 ml. So it confirms the spread of contrast before, one should confirm the spread of contrast by contrast of the spread of local anesthetic agents. And the local lidocaine use is 1 to 2% and bupivacaine is 0.25%. Similarly, face it, the volume gets further lower. It's around 0.5 ml. And in Stillet, ultrasound guided C6 approach is better. Landmark technique carries greater risk. Bupivacaine is given in 0.5, but little more volume, that is 5 to 8 ml, and lidocaine 8 to 10 ml. But what is important is that those places, those physicians who don't have ultrasound guided, one should know their landmark techniques for giving optimal results to the patients, especially where you need a synthetic blockade. So it can be given, local anesthetic can be given in spinal anesthesia, all of us know, peripheral nerve blocks, and this ropivacaine, bupivacaine are the most commonly used. So they can also be given by continuous catheter infusions of ropivacaine and bupivacaine. The trigger point injections, lidocaine with steroids is mostly what we are doing, but dry needling these days, ultrasound guided, has increasing being used. Although sometimes still we use wet needling, reduced post injection soreness, and that is what is done sometimes. Intraarticular, knee, shoulder, hip, bupivacaine, ropivacaine. Higher concentrations of bupivacaine are avoided because it causes chondrotoxicity risk. Lidocaine is a very versatile drug. It can be given in a infusion form, amla cream, patches. So when it is given as an infusion, usually it is neuropathic pain, fibromyalgia, postoperative analgesia and ERAS protocols, but it is not very commonly given. And we have used it in neuropathic pains and CRPS along with the ketamine, which I'll be discussing later. But ECG monitoring is very important in these patients. Overall blood pressure monitoring and ECG monitoring throughout. So amla cream, it's a lidocaine and prilocaine mixture. Topical skin anesthesia before you give capsaicin in neuropathic pains, and this capsaicin can be up to 8%. So it will be extremely painful. So if you don't use amla cream before that. So ultrasound guided dry needling, you have to put amla cream prior. Botulinum toxin, which we do frequently, also requires amla cream application and making the skin numb. and this should be applied 45 to 60 minutes before the procedure. So lidocaine patch is it's a first line of option in post-herpetic neuralgia. It is 5% transdermal patch, and systemic absorption being very low, less than 3%. It has a low toxicity. And one thing these days, even for the joints, a lot of people are using lidocaine patches for inflamed joints too. Now, the role of corticosteroids in pain intervention. This is a drug which is widely used by us as pain physicians. And all of us know that steroids are categorized into classified into three categories: glucocorticoids, mineralocorticoids, and sex steroids. So the glucocorticoids are from adrenal cortex zona fasciculata, and the drugs which are most commonly used out of this group is prednisolone, methylprednisolone, and triamcinolone. It's a long-acting, also dexamethasone and betamethasone. Mineralocorticoids are from zona glomerulosa, and the hormone is aldosterone, and its synthetic version is fluorocortisone. And the sex hormones is from the adrenal cortex zona reticulata, and usually hormones are DHEA or androstenedione. So what is the mechanism of action of corticosteroids? It causes membrane stabilization by decreasing the ectopic discharge, reduces sensitization of dorsal horn neurons, blocks C fibers, edema reduction, neural effects, phospholipase A2 inhibition. And the overall effect is anti-inflammatory, anti-hyperalgesic, and membrane stabilization. So steroids use, where all we are using as pain physicians in intralamina and caudal epidural steroid injections, and frequency is usually maximum 3 per year, usually 6 to 8 weeks interval. It has a level 1 evidence for radiculopathy. Transforaminal epidural steroids are also superior, when especially it is good when single level radiculopathy is there. The frequency in all these are 3 to 4 per year, and minimum of, it depends, 3 to 4 weeks are given. So, facet joint injections, again, short-term relief proven, long-term data is still limited about it. But medial branch block is something which is more frequently done, followed by RFA. Intra-articular injections in knee, they are also not given more than 3 to 4 times per year, and glycoprotein degeneration concerns beyond 4 injections per year. Level 1 evidence for osteoarthritis, steroids less than or equal to 8 weeks benefit is usually there. Similarly, shoulder, comparable to NSAIDs at 4 weeks, benefit wanes, and maximum 3 per year. And 2 months, 8 weeks minimum interval is required. Sacroiliac joints is also level 2 evidence. RFA is more durable for SI joint injections. So, role of steroids, that transforaminal, what is its role in transforaminal epidural steroid injection? Transforaminal epidural targets the affected nerve roots in radicular pain. But, if you look at the literature, it says that it is clinical effectiveness of adding steroids. It is no added steroid benefit has in lumbar disc herniations. Even in cervical radiculopathy, it says that no difference at 3 weeks. Blocks combined with pulse radiofrequency adding steroid did not improve more than 50% pain relief, even lasted longer. Although practically all over the world, all the pain physicians all over the world are using steroids, but the literature is it's little concerned about the safety and doses of the steroids, because the serious neurological events after transforaminal epidural steroids, although rare, but have been mainly because of the particle steroids, inadvertent intra-articular injections have been reported. And the comparative trials show that non-particulate dexamethasone is equivalent to triamcinolone, and effectivity for lumbar and cervical this transforaminal injection, and only small differences are there that more injections are required if dexamethasone is given. So the dose finding RCT suggests that 10 milligram this Kenacort is reasonably, this is the trade name of this triamcinolone, is a reasonably minimal effective dose. And the higher dose did not clearly improve the short-term outcomes. So this is what the literature and evidence says. And use of corticosteroids for other pain procedures by ESRA guidelines 2024. It says that addition of corticosteroids to local anesthetic is recommended in greater occipital nerve blocks for cluster headache, ilioinguinal iliohypogastric genitofemoral nerve blocks for post-herniorrhaphy pain, and injection for Morton neuroma pain. And the addition of corticosteroid to local anesthetic is not recommended in sympathetic nerve blocks, greater occipital nerve block for medication overuse headaches or migraines, pudendal nerve block for pudendal neuralgia, or injection for carpal tunnel syndrome, and trigger point injections. So corticosteroid, is now divided mainly into particulate and non-particulate. The particulate steroids are methylprednisolone acetate and triamcinolone acetonide. The potency is 5 times the cortisol. Their onset is 24 to 48 hours, and duration is 3 to 4 weeks in depomedrol group, whereas in Kenacort group it is duration is 3 to 6 weeks. So they are given in different doses for epidural joints, facets, depending upon the requirement you feel. But usually it is Kenacort is given in a slightly lesser dose, around 20 to 40 milligrams, and whereas depomedrol is given usually 40 to 80 milligrams, except in facets where you give even much lesser, 10 milligrams. So non-particulates are dexamethasone, sodium phosphate, also known as decadron, or betamethasone. So their potency, they are high potency drugs, like they have 25 to 30 times the cortisol levels. Onset is also earlier, that is 12 to 24 hours. The duration is 2 to 4 weeks, which is much lesser than the particulate ones. And the dosing is epidural is 4 to 10 milligram, transforaminals 8 milligram, perineal 8 milligram. Usually we give around 8 milligrams if we have to give dexamethasone. But betamethasone is not given neuroaxially, things, but it is used in joints and soft tissues. They have a good anti-inflammatory actions. So what is the distinction between particulate and non-particulate? Because their appearance is milky suspension, that's how you identify them. Whereas non-particulate are clear colorless. Particle sizes usually more than 100 microns. But the other side, no particles, or it is fully dissolved. And since it's a colorless solution also. Aggregate is formed when mixed with local anesthetic. No aggregate is formed in non-particulate. Interlaminer, acceptable. It is acceptable with low risk route. Acceptable, both are acceptable for interlaminer. But transforaminal, it is contraindicated by ESRA guidelines, but it's a first line of choice. The non-particulate are the first line of choice for transforaminal epidurals. Caudal, both are accepted, and the duration of benefit is slightly longer, as I already said, in particulate versus non-particulate. So, so far as safety concerns are there, FDA has issued a black box warning on triamcinolone and methylprednisolone for epidural use. The particulate steroid inadvertently injected into radicular artery can cause embolic occlusions, spinal cord infarctions, paraplegia, quadriplegia, and these are permanent and really, really distressing things. And sometimes even if it goes intra-articular, they have seen causing brain infarcts too. There are few studies, few case reports of brain infarcts. So what is, usual guidelines have been again. Some suggest that current role of particulate steroid should be limited to caudal or interlaminer approach, or TFSI in lumbar spine, because that is slightly wider as compared to thoracic and cranial, cervical, sorry. So they should be administered non-particle steroids if cervical and thoracic transforaminal epidural steroids are necessary. So now, what are the adjuvants in adjuvant pharmacological agents which we use routinely? So why do we need the adjuvants? They cause better localization in the case of contrast, prolongation of analgesia, improved quality of analgesia, opioid sparing effect, faster onset of block, dose reduction of local anesthetic, anti-inflammatory action. So because of all these advantages, adjuvants are added. So the contrast, this is the first thing which we it's very important. And for residents, there's so usually 2 to 3 questions in the exam which come from the contrast. And the contrast is used for accurate localization of needle position before injecting a local anesthetic, steroid, or neurolytic agent. So it is more important for especially for steroids and neurolytic agents. Judicious use of contrast medium helps to localize is precise anatomic location, prevent aberrant spread of injected, and reduces fluoroscopic time. While injecting perineurally, inadvertent intravenous or intrathecal injection should be avoided. So these contrasts are usually positive contrast or negative contrast. So positive contrast absorbs X-ray, looks darker on fluoroscopic views, and lighter shadows on X-ray films. And for example, iohexol, iopamidol, and all these drugs. And negative are more transparent to X-rays than body tissues and produce lighter shadows on fluoroscopic skinning. And these are usually gases: air, nitrogen, carbon dioxide, helium, oxygen, nitrous oxide, xenon. And another which is very important is a gadolinium. This is a contrast, which is used for paramagnetic MRI contrast agent that enhances T1 weighted images. It's an alternative contrast medium used in patients with iodinated contrast allergy, but with one caution that this is not to be used in the central neuroaxial blocks before that. So these are the various drugs. This comes with the trade names Omnipaque, Isov, Visipaque, and Opitrate. The diatriosate is gastrographin or urographin के नाम पे आती है. And they have 2 concentrations, which are lesser concentration and higher concentration. Lesser is around 200 milligrams, and higher is usually 350 milligrams. And these are the drugs. Lower concentrations are more useful, and they say that it's more effective. I mean, causes less reactions versus the thicker ones, which are the higher concentrations. And the maximum recommended safe dose for contrast medium is 3 grams per day. So it usually comes out to be 15 ml, 10 to 15 ml per day. And they are used in different procedures. You can see various, as we have already talked, and they are intrathecal. Upper 3 are intrathecal safe, which are non-ionic. The levetiracetam optirate, it is off-label use, and so it should be used with caution. But the ionic, which is the diatrizoate, is not used in pain and because it causes neurotoxicity. But this, when above are not available, so one can try, but this should be avoided. Ionics are always avoided. So what the allergic reactions already, although said 1 to 3% index, it's mild. Severe are very rare. And pre-med, in case you suspect your patient is very sensitive, then you can give prednisolone as as a pre-medication. 13 hours, 7 hours, or 1 hour pre-procedure. Cetirizine can be given, ranitidine can be added, and resuscitation things should be available. And confirm the placement. 1 to 2 ml contrast should be given first before you give the more. But practically, I learned over the years, initially we used to inject 1 cc. Then over a period of time, we learned that 0.5 does the same job. But sometimes when you are doing the procedure, it still blotches if you are in a wrong place. So it becomes very important that you inject just 0.2 to uh, mm, uh, 0.2 or 0.3 ml initially. If it blotches, then you can refrain. Otherwise, you can make it 0.5, and 0.5 also gives a good thing. But sometimes when there are a lot of blockades, then you might have to give 1 ml contrast medium in pain practice. So epidural pattern, bilateral contrast spread in AP lateral should be checked. Avoid intravascular patterns, vascular blush or rapid washout. Once it is in the artery, it's quickly taken away. So then you know that you are in the arterial. If you have injected contrast and on fluoroscopy, you find there's no contrast there. So that's very clear that it has gone into the vascular, and so you should be very careful, and you should abort that this thing injection and reposition your needle. So life, and that is why, especially for the cervical procedures, we always do live fluoroscopy. And there are other where are richly supplied by vessels. We always try to do a real time while injecting the contrast medium. So nephrotoxicity, and those patients who are diabetic hold metformin, especially on metformin, should hold it. Hydrate these patients very well, and they say that hydrated patients cause less toxicity. And gladiolinum, as I already said, it is not approved for interventional spine procedures because it causes nephrogenic systemic fibrosis, and in severe CKD patient, it has been reported. So what is important in contrast, that you should record the agent, the volume, the concentration, the route of administration, document any reaction immediately, report adverse effects to institutional safety systems. Informed consent should be taken. When you're taking informed consent, do take a for the reaction, allergic reactions. And this is what ESRA pain medication recommendation. This has come out very lately, 2025, that there is a shortage of contrast. Although we people are not facing that much of shortage of contrast, but worldwide probably they are facing. So that's why ESRA guidelines have come up on this. And they have said that this guidelines say that when there is a shortage, then until unless there is an urgency of treatment, you can delay till contrast medium is available. And they said for lumbar transforaminal, when you're doing it without contrast, just by localizing the needle, do not use particulate steroids, use non-particulate steroids. And lumbar interlaminar parasagit, like instead of transforaminal, you can do it with interlaminar paramedian or parasagittal approach. That gives almost same results as TFSE ESI. So contrast is not necessary in these paramedian and parasagittal approaches. So that can be saved. So in cervical interventions, when you are without contrast, one should be very careful, and one can use ultrasound, and non-particulate is preferred. In any way, it is preferred. But if there's a shortage, so then ultrasound guidance is a better option. So this we have talked that non-spinal intervention, it is not to be given, but it can be utilized for other places. What can we do if we have a single vial, and can we use for multiple doses? Yes, multiple should be used. Multiple dose vial can be used for single patient. Like his patient is coming this week, and is going to come after 3 weeks or 4 weeks. We can keep it in the fridge and we can reuse it. But in case multi-dose vial, more than you have to use it for more than one patient, then one should follow CDC guidelines. So another drug, which is initially when we started our practice, it was a common practice to use hyaluronidase. Hyaluronidase was used much more frequently at that time, around 20-25 years back. But nowadays, this is much less used. But whenever it required, it's an enzyme derived from bovine or ovine testes. And now human recombinant is also available. It depolymerizes hyaluronic acid in the interstitial matrix, reduces connective tissue viscosity, enhances drug diffusion. So obviously, where there is a fibrosis, So there it is really useful. So RACs can caudal epidural fibrolysis, enhance spread of subcutaneous infusions, or ease of catheter tip during drug delivery implanted pumps. It can be used. It is mainly used in the dose. It is available in 150 international units to 1500. But in India, what is available is 1500 international units per ml. And typically we use 1500 it's in the powder form. We have to dilute it with the saline, or sometimes we directly dilute it with the local anesthetic agents, and and then withdraw and use it. So Rex as epidural, I already said that 1500 international units can be given. But what is why it went into not very commonly used? Because mostly which is available is allergic. It's bovine and ovine source, and that many people are allergic to it. So skin testing is very, very important, and one should check it. And recombinant, if available, one can use as alternative in known sensitivity patients. Systemic allergy, although rare but documented. So, what are the precautions one should take when if you are using a hyaluronidase? Do not inject into infected and inflamed area. Do not use near the tumors. Potential facilitation of metastatic spread has been seen. The test dose of for allergy intradermal should be done, and do not give IV. That's very important. Initially in our protocols, always we that was added up, but now not anymore, except when you are suspecting a lot of fibrosis. So, opioids are not commonly used in, it's adjuvants, but not very commonly used in pain practice, except in cancer pains. So, in cancer pains, your end of life stages, it is very common to use this thing. Plus, it has a role in acute post-op pains. Ketamine, it was a drug of choice a few years back. In fact, I had got my few postgraduates serial wise. We used to give different doses of ketamine epidurally in low back pain, and actually, I found a very good results. But when we wanted to publish it, so then that time it came that it is a neurotoxic. And when I checked up the literature I quite checked up in details, and there is only one case report of neurotoxicity. That also they said they are not sure that it was a ketamine neurotoxicity. And one study which they said, just on the basis of one study, which was stopped in between. And they started saying that it has a potential for neurotoxicity. As ketamine is preservative free, it is a good. I mean, it can be given, but it is not freely available. So racemic mixture, potential of neurotoxicity, not given as a very commonly nowadays. So it is an NMDA receptor antagonist. It has anti-hyperalgesic action and adjuvant for cancer pain, intrathecal drug delivery systems, emerging role in refractory pain syndromes for subarachnoid ketamine. But IV infusion, as I already said initially, it can be given in subanesthetic doses, opioid refractory pains, cancer pain, CRPS. And 3-day infusion protocol in pain units reduces opioid hyperalgesia and tolerance. Psychomimetic effects can be mitigated with midazolam. And this drugs, I have used it in quite some patients, but somehow I'm not very happy with the ketamine and lignocaine infusion. My results have, our results have not been very good as we expected them to be. But yes, many people have found it very effective. So, out of the commonly used these adjuvants, we have already talked about, is another one is the alpha 2 agonist dexmedetomidine, and this can be given epidurally in nerve blocks, and that is comparable or superior to hyaluronidase in trials. Vasoconstrictor, we have already talked about epinephrine, that it prolongs the local anesthetic effect. The other adjuvants, in addition to the above, are soda bicarb, and it increases pH, more ionizes local anesthetic, faster sodium channel entry, faster onset, shortens onset by approximately 30 to 50%, which is quite a bit. And it is not added with bupivacaine is not added with soda bicarb because it precipitates, and it has to be once prepared. That preparation of local anesthetic is to be used within 6 hours. Another drug, neostigmine. This is not very much used in pain clinics, but yes, it is additional drug which is used intrathecally or epidurally for more of the acute pain, and also it is useful in opioid tolerant patients. Midazolam, it intrathecal, it causes spinal GABA A receptor potentiation, anxiolysin and sedation at supraspinal level, prolongs the spinal anesthesia, anti-nociceptive at dorsal. Only preservative-free preparation should be used. And dose is 1 to 2 milligram intrathecal, preservative-free. Magnesium sulfate, this we have used quite a bit. I use it for almost 2 to 3 years, magnesium sulfate, as when ketamine was said that it is a neurotoxic. So another NMDA receptor antagonist was magnesium sulfate, which we used. This prolonged sensory motor duration and analgesia without additional sedation. It has opioid sparing effect, and the 2024 meta-analysis has a strong evidence for neuroaxial administration. I personally also have good experience with this, but probably it went away with the thesis only. For 3 years we use it, and now I feel we are restricting it. So liposomal bupivacaine, although it's not available freely, but it is also FDA approved for wound infiltration tab blocks, interscalene blocks. And it is not currently used approved for neuroaxial use. Other drugs which are our, in armamentarium is neurolytic agents. So neurolysis, what is neurolysis? Neurolysis is the intentional destruction of neural tissue to achieve long-lasting analgesia in refractory pains. And the type of neurolysis is done is chemical, thermal, cryonucleolysis, neurolysis, and emerging is molecular neurolysis, which is still in a research stage. So the goal is to interrupt nociceptive transmission at peripheral or sympathetic levels. So various drugs which have been used are ethanol, or we call it absolute alcohol, which is used in the concentration of 50 to 100%, phenol 5 to 12%, glycerol, radiofrequency ablation, although these are not the agents, but these are the techniques. Radiofrequency ablation, pulse radiofrequency, cryoablations, botulinum toxin, capsaicin in high doses. So they are categorized differently: chemical, thermal, neuromodulations, and so on. And they have a different onsets. Ethanol and phenol. Phenol is comparatively slower, and ethanol is slightly more. Both have, their effect lasts from months to years, but ethanol is mainly used cancer pains. Phenol is used in mixed pains. Glycerol in neuralgias, radiofrequency in facet joints and other procedures, and pulse radiofrequency for neuropathic pain, cryoablation, intercostal neuralgias, post-thoracotomy pains, botulinum toxin for myofascial neuropathic pains, trigger points, capsaicin for neuropathic pains, and so on. So these are the two drugs which we commonly use, ethanol and phenol. These are most commonly used, but even more than phenol, ethanol is being used because there is an issue with sterilization of phenol. So there is a pain on injection is severe with ethanol and very less with phenol. That was one of the reasons that phenol in some institutes is used quite a bit. But I always find it difficult to sterilize, and our biochemistry department doesn't provide us in very nice way. So I try to contact maybe those colleges where phenol is being prepared by biochemistry department. They have availability. So onset is rapid in ethanol and slower in phenol. Spread less predictable. Phenol is more controlled. Potency is higher. In phenol, it's moderate. And preferred use is plexus neurolysis. And phenol can be given intrathecally and peripherally. And it has a local anesthetic effect also, the phenol. So what are the various procedures which require these neurolytic agents? See, this plexus blocks, ganglion impar, medial branch ablations, trigeminal neuralgia, intercostal neuralgia. So these are the various techniques or agents which have been used in these procedures. So what is this safety, toxicity, and complication? The first thing when you talk of toxicity comes the local anesthetic toxicity, which is last. The risk, the bupivacaine has the highest incidence as compared to levobupivacaine, ropivacaine, and lidocaine. And it is mainly lipid solubility which increases the toxicity. And the factors are elderly, hepatic diseases, lean body mass, pre-existing cardiac diseases, acidosis. The procedural factor, high vascularity sites, lead on to a lot of complication. Excessive dose and volume, and inadvertent intravascular injection is a common cause for last. And how it presents is, all of us know, because most of us are anesthesiologists by degrees. So perioral tingling, metallic taste, tinnitus, lightheadedness, agitation, slurred speech, tonic-colic convulsions, seizures, coma, in cardiac tachycardia, ventricular arrhythmias, asystole. Bupivacaine toxicity always there in bupivacaine. Cardiac toxicity precedes the CNS signs. And the treatment protocol, all of us know: stop the injection, call for help, 100% oxygen. If there are seizures, midazolam, thiopentone, propofol, intraleukin is a drug of choice. And bolus of 1.5 ml per kg over 1 minute, infusions followed by infusions. And the total dose maximum is 12 ml per kg. Patients can have a cardiac arrest. CPR standard protocols should be followed, and they should be observed post-event for 4 to 6 hours at least. Steroid toxicity. Once any patient, usually what we face is patients will ask, "Doc sab, steroids ke koi side effects to nahi honge?" So we are to inform them the side effects, and the most common are endocrine, which are transient hyperglycemia, especially if patient is diabetic. So we have to say you have to get regulated your doses, and your sugars are going to get higher. So HP axis suppression, which is usually 2 weeks to 4 weeks. We did one study and we found approximately 3 weeks, this HPXS comes to normal, and in our study, but the literature says approximately 4 weeks. And in some patients, very rare patients, up to 6 weeks also there can be a suppression. But usually epidural steroids don't cause that long. Oral steroids, yes, it can be up to 6 weeks. So Cushingoid features with repeated injections, menstrual irregularity in women, it's very common. You have to inform them, otherwise they come back and the complaint they have is the menstrual irregularity. So osteoporosis also very common in women, avascular necrosis of femoral head, tendon degenerations, subchondral bone changes. They can be, there. So one must inform the patients. And infectious epidural abscesses, meningitis, reactivation of herpes, or is not that common, but yes, if patient already has infection, it can really get flared up, especially UTI. I always ask the patient, do you have if it is he or she is a diabetic, this is very common. So this flaring up of infection is something, or at least just ask anywhere in the dental problem, any other problem, it is going to get flared up. So neurological, cardiovascular, and relative contraindications are not that common versus the upper three side effects. So allergic reactions can be mild, moderate, anaphylaxis, or severe, or it can go up to cardiac arrest. So adrenaline is a drug of choice for this, and CPR might be required if there is a cardiac arrest. So what is very important, initially when we started, we were taught that pre-post procedures are important. Certain things are important, but I learned over a period of time, very early in my practice, that these are very, very important. That's why I'm laying so much stress on these. If you are using, drugs, doing pain clinic, you must have informed consent. You must ask the history of allergy, anticoagulation status, they may not tell you sometimes they are on anticoagulants. You must ask in details. We have a form where we get them ticked. These things are quickly, it just takes 2-3 minutes to document all these things. So IVSS is always established in our patients. And before giving local or any procedure, we make it mandatory to put an IV line. So baseline vitals are monitored, coagulation profile, if required. In case if patient is on anticoagulants, we do take them coagulation profiles. Fasting status, we always ask them. But we are not very stringent because these patients come directly from home, from so far away. We tell them to take light meals. Aseptic techniques, sterile preparations, drape, mask, hat, everything. And sterile potty is very
बिल्कुल
important.
उनको याद भी नहीं होगा फिर
Resuscitation equipment should be checked. Intraoperatively, intraoperatively continuous monitoring. We do all the monitoring very thoroughly, all the patients. So non-invasive BP, verbal contact to be maintained with the patients. And sometimes like we do give sedation, but we make it sure that we have a verbal contact with them, because sometimes, and the literature does say, there has been spinal cord stimulators implanted into the spinal cord because the patient was in a deep sedation and patient could not know. There are case reports and there are so many complications written about the deep sedation. So real-time fluoroscopy, ultrasound guidance, whenever we are doing procedure, is always handy. These days, ultrasound is used like a diagnostic tool. It's like a history taking. After history taking, checking the things directly by ultrasound. Aspirating before injection. This is something, I have a very interesting story to say. There was a flail chest patient. The last day, 5 days, I kept the patient very pain free. Last day, just before taking out the catheter, I did not aspirate and I just injected the drug and took out. And the patient said, "Doctor साहब आज मजा आया, सारा शरीर हल्का हो गया." And within a minute, he lost the respiration. I lost my respiration. And, he was in I mean, I had a tough time. I lost my breath that day. So after that, I never inject without aspiration. So it could be CSF, and I'm sure, and we have avoided so many times. My residents tend to, क्या फर्क पड़ता है, छोड़ दो. But I may always tell them कि जब post operatively and if you have to give analgesia, please check aspirate. Contrast confirmation of spread before definitive injection, slow incremental injections, live fluoroscopy, especially if you are doing transforaminal injections. So post procedure, we always observe the patient in recovery room 30 to 60 minutes. Vitals are checked and assessment motor block if local anesthetics are used, because sometimes when we give a femoral nerve blocks, patients are unable to walk, or even for that matter, when difficult epidural is there or difficult spinal procedures are there, motor blockade can occur because of the local anesthetics. Discharge criteria, LDRET scores, written discharge instructions are very, very important. Many a time they don't even know when they are getting steroids. You are not telling them dietary precautions and other things. They come back with so much of weight gain, and then it becomes very difficult. So you have to inform them, or you are using drugs along with that anticonvulsant and antidepressant. You must instruct it properly that what they are going to feel. Then warn them of post-injection flares. Antibiotic cover always in if steroids are given. So it's always a good practice to give antibiotic cover. So follow up 2 to 4 weeks to assess them, and documentation of drug dose, volume, image confirmation, and everything is done. And we maintain the register so meticulously. Everything is noted down. Sometimes we don't want to give it to the patients directly until unless they ask for, because they tend to misplace. We used to document on their slips, but no more. We do it in our register, so that remains as a record with us. So these are the summary points for different procedures, the first line drugs and the doses. And the residents, I would say that they can click this photograph of this and they can read it up later on. I've already discussed almost everything, but just in case for ready reference, this slide and this slide, they can click it for ready reference. So takeaway is local anesthetic mechanism, sodium channel blockade. They choose agent by onset, duration, and potency. Differential block preserves the motor function at lower concentration, which is very important for as a pain physicians. Particulate steroids must be avoided for transforaminal epidural injections. Non-particulates are not less efficacious as the trial data supports the outcome. Adjuvants extend, block, and improve analgesia. Neurolytic procedures require robust consent and precise image guidance. So, dexamethasone prolongs PRFA or RFA outcomes. Last is preventable. Respect maximum doses. That is why I stressed initially. Aspirate always. Inject incrementally. Never give just as a one shot. And I've seen a lot of complications when it is given. This is not followed. Injecting incrementally. Nothing may happen for so many patients, but one patient is sufficient cause your trouble. Always have intralipid available, 20% available in your OT, or it should be there once you are using a local anesthetic. So early recognition of prodrome, that complication of last, should be recognized so that you can avoid scissors and or critical incidents. Thank you so much. So now,
Thank you, ma'am.
how do I pause?
So it was a very informative lecture, even for me. So if anybody is having any question, they can ask in the chat box. We can take the questions one by one.
There are two questions in the chat box probably.
Ma'am, in cases of knee effusion, non-infective due to osteoarthritis, which intra-articular drug is better, steroids or hyaluronic acid, and why? This is some iPhone user has asked. Please disclose your name. So, ma'am, question is like that: if patient is having knee effusion due to osteoarthritis and it is not infective, then what should we give, steroid or hyaluronic acid?
I think these days we are more looking for PRP rather than steroids or hyaluronic acid. I mean, if it's short term, yes, the patient wants a quick release, steroids are good. Hyaluronic acid also, they have a similar duration almost. Steroids also 4 to 6 weeks or maximum up to 8 weeks, and similarly hyaluronic acid also. PRP comes little late, but it lasts longer, much longer.
Mostly, madam, basically synovitis causes the knee effusion, thickening of synovium. So it depends on the condition of the
But he
knee.
says it's because of the osteoarthritis. Yeah, because
नी
of that
फ्यूजन
also.
साइनोवाइटिस है तो वहाँ पे लोकल जाइलोकार्ड विथ स्टेरॉइड हेल्पफुल होता है मोस्ट ऑफ द टाइम में, पर नी कंडीशन पे डेवलप डिपेंड करता है कि अपने को हाइल्यूरोनिक एसिड देना है या हाइल्यूरोनिक एसिड प्लस स्टेरॉइड देना है या केवल स्टेरॉइड देना है.
But osteoarthritis may, they are all temporary.
यस मैम.
They will, even if you give steroid, it will not last more than 2 weeks, 8 weeks. It will not last more than 6 to 8 weeks.
Yes, ma'am. Steroid is preferred in cases of synovitis and effusion due to synovial irritation only.
Yeah, if there is no effusion, then probably hyaluronic acid will act better.
Yes, yes, ma'am.
If you want to choose between the two. So, what are the particulate steroids contraindicated? Are particulate steroids contraindicated? Yes, literature says that it is contraindicated for transforaminal epidural steroids, but mainly for cervical and thoracic. But these days, people are using carefully for lumbar transforaminal. They are using, and after a contrast, after checking contrast that you are not in the arterial or anything like that, and they are using it. But for cervical, yes, it's total no.
So, any other question? Hope session, hope madam is covered topic very well. There are very less questions are there. So, madam, we can conclude the session over here.
Yeah. Thank you
Please
so much.
stop the recording from your end. You have started the
Okay.
recording.
Recording is from here. Stop recording.
Okay.